Hello, I'm Bob Falcone. I'm the CEO of the Columbus Medical Association and its affiliates. The CMA thought it was very important that we catch you up on some important coronavirus pandemic information. What I'll do is talk briefly about the history of pandemics in the last 100 years. Dr. Nicholas Kamen, who is a professor of emergency medicine at The Ohio State University and an expert in pandemics, will talk about the COVID-19 pandemic. And Jody Keller, who is our lead executive at the Central Ohio Trauma System for disaster management and prevention, will be talking about what we're doing regionally. In the 20th century, there were four major flu pandemics: the Spanish flu 1918 to 1920, the Asian flu 1956 to 1958, the Hong Kong flu 1968 to 1970, and the swine flu 2009 to 2010. The slide you're seeing shows a century of flu. On the left, what you're seeing is city police from Baltimore ready for action. And on the right, you're seeing a woman in Iran protecting herself with a face mask. Interestingly, we're still not 100% sure how much good cloth masks can do in preventing spread. So the Spanish flu, it was an influenza A. They are all influenza A, by the way. H1N1 variety. It's not sure where it came from, but it was probably Asia. This was during World War I, and no country wanted to give its enemy any potential advantage, so they weren't reporting flus in their countries. Spain was neutral, and it reported honestly, so this became the Spanish flu. It was first reported in a military base in Kansas in the spring of 1918 and continued for 3 successive waves. There were 500 million infections, 50 million deaths worldwide, and 675,000 deaths in the United States. It had a high mortality in those aged 20 to 40 years of age. And that mortality, at least half the time, was due to a primary viral pneumonia. The other half, it was due to bacterial superinfection. We didn't have antibiotics or antivirals or critical care, so the basics of treatment were supportive care with an emphasis on prevention. Let's talk about prevention of spread. What you see in front of you is a slide of 2 cities to contrast. One is Gunnison, Colorado in 1918, that's on your left. And the other one is Philadelphia, PA in 1918, that's on your right. Gunnison was a farming mining community of about 1,300 people. It sat in the confluence of 2 transcontinental railroads. It decided as a city to quarantine itself against the world. It erected barricades, sequestered visitors, arrested violators, banned parties and street gatherings, and locked down for at least 4 months. The picture you're seeing is people disembarking from one of the railroads that crossed Gunnison, being immediately arrested and put into quarantine. Gunnison did not have a single incidence of the Spanish flu. On the right, in Philadelphia, PA, in September, there were 600 sailors infected with coronavirus. 1 week later, the city decided to go with a parade which had been previously scheduled. A month after that, there were 635 new cases, and 6 months later, there were 500,000 new cases and 16,000 deaths. Clearly, isolation and quarantine makes a difference. Asian flu, 1956 to 1958. This was an influenza A also, H2N2. It probably originated in China in 1956. It was first reported in Singapore, February 1957, and it was reported in the U.S. summer of 1957. It also continued for 3 successive waves. Bacterial superinfection accounted for 50% of the deaths. We did have antibiotics, but didn't have very much in the way of antivirals, and we had very rudimentary critical care. Worldwide, there were 1.1 million deaths, and 116,000 of those deaths were in the United States. Hong Kong flu, 1968 to 1970. Also influenza A, H3N2, probably the result of antigenic drift. Think mutation. It originated in China in July of 1968, first reported in the United States 3 months later, and also occurred in 3 waves, 68, 69, and 70. 1 million deaths occurred worldwide, 100,000 of those were in the U.S. This flu continues to circulate as a seasonal flu today. Because of mutation, it requires frequent vaccine updates. Swine flu, 2009 to 2010. This was a novel influenza A H1N1. By novel, we mean that most of the population was not previously exposed to it. It originated in the U.S. in April of 2009, and the WHO declared a pandemic on July 11, 2009. It continues to circulate today. It is sensitive to antivirals, vaccines are available, and of course we have modern antibiotics and critical care. In the U.S. there were 60 million cases, 300,000 hospitalizations, 12,000 deaths. Worldwide there were 1.4 billion infections, 150,000 to 575,000 deaths. So for the four pandemics, Spanish flu, 50 million deaths, 675,000 of those were in the U.S. Asian flu, 1.1 million deaths, 116,000 of those were in the U.S. Hong Kong flu, 1 million deaths, 100,000 of those were in the United States. Swine flu, 150 to 575,000 deaths worldwide, 12,000 of those in the U.S. Clearly, sound public health reporting and prevention, antivirals, vaccines, antibiotics, and critical care have made a difference. Have we learned any lessons? First of all, flu is seasonal and predictable, and pandemics have all been influenza A. COVID-19 is different, which makes it much less predictable and more worrisome. Good, sound public health measures work. Good hand hygiene, social distancing, quarantining for disease, closing borders make a difference. Early reporting and communication helps. It helps disseminate important information, and it keeps the population from panicking. And of course, our contemporary medical milieu in the United States is absolutely top of the line, which helps us ensure that those people who do get sick get treatment, with the vast majority surviving.